Wild Health is about optimizing you. We use genomics, blood work, biometrics, microbiome assessment, many other tests, and a conversation with you to come up with a full health optimization plan. What's the perfect diet, exercise, and supplement plan for you and only you? The Wild Health podcast is about optimizing all of us. Here we cover the cutting-edge science that gives you the base to be able to apply the personalized plan we give you as a patient. To sign up as a patient, go to wildhealth.com. Or if you're a physician or health coach and you want to learn how to do this for your patients, we're happy to help as well. Wildhealth.com for all the information on becoming a patient or working with us.
Hey guys, welcome back to the Wild Health Podcast. Dr. Jeff Graham with you here today, the Chief Medical Officer at Wild Health, and I am thrilled to be talking about stem cells today with Dr. Mattias Bernow. Before we get started, I'm going to give you a little introduction and talk about some of what we're doing at Wild Health with stem cells. You know, this is a really exciting field. A lot of our patients are coming to us now asking about this, so we're thrilled that Dr. Bernow has joined us. So welcome.
Thank you, Jeff. Thank you for having me.
Yeah. So I'm going to give a little introduction, and by way of introduction, I'm going to feel like a massive slacker because looking at everything this guy's done is blowing me away. This is just gonna really highlight some of your career, some of what you've done with your life thus far, and then jump into some of the practical science behind this stuff that you're doing, and so that we can educate our listening audience about stem cells. You are an MD, an economist, which I found really interesting, and the CEO of Cellcolabs, here to give us a clear, evidence-driven tour of where stem cell therapies are actually working today and what we think the future looks like. Dr. Bernow trained at Karolinska, that's right? Is that how you say it? Okay. And co-founded a digital health company, Doctrine. He worked as a consultant at BCG and now leads large-scale production of clinical-grade stem cells. So he is uniquely placed to talk about both science and scale. Hopefully, you guys today will come away with some practical takeaways, such as which indications have solid evidence, how different cell types and delivery methods compare, and what to watch for in these upcoming trials and industrialization. So thanks for joining us, Dr. Bernow. Does that all sound right?
Wow, that's a long resume, but
Yeah.
I promised I never intended it to be that way. When you look in the rearview mirror, you want to have a red thread and a clear line. This was never my intention. I started out in business school, and I thought it was amazing. That time, everybody was going to London or New York to become bankers, and coming from a family in a smaller town in Sweden, from a family of doctors. My parents strongly advised me not to become a physician. In Sweden, it's a line of work where you're employed by the public. It's not a very great working environment, and it's not the salary you would expect if you live in the US or elsewhere.
Yeah.
So I started business school instead. Loved it from day one, though realized after a while that I didn't want to become a banker in London or New York as everyone else in my class. So I snuck over to med school instead at Karolinska in Stockholm. I loved that from day one as well. Though I kind of missed the extrovert entrepreneurial students at business school. So I studied med school, I hang out in business school. There's some kind of manic episode I ended up with double degrees, and now has been my stroke of fortune. I love to be with one leg in each world, and to be to join those two worlds for the better of the patient and for my colleagues and healthcare overall.
Yeah, it's a very unique combination. You know, I think you'd actually fit in well at Wild Health. We all live in a slight state of hypomania, and I think it keeps us, both on that bleeding edge of medicine and also, able to provide this top-notch care for our patients. We're so proud of. I wanted to say probably the thing that is most impressive about everything we've said so far is that you're actually maybe our farthest traveling guest, if you can count that in the podcast world. I'm talking to Dr. Bernow tonight. He's in Stockholm. It is 10, almost 11 o'clock there.
It is at
Yeah.
9.
And he just shared with me that his 4 and 6-year-old sons have been circulating a GI virus in the house. So I am super grateful that you're checking in to talk to us today. So thank
Thank
you.
you. So happy to be here. Family sleeping. This is my time, and I love to spend it with you and your audience.
Good. I love it. I love it. So it's wonderful to have a natural night owl on the podcast when it's 11 p.m. at night. Um, so let's kick this off. I think, one of the very first things that I hope to accomplish in this interview was to give our listeners a basic stem cell 101 so that they understand the science a bit better. I'll kind of lead into that with a bit of a prompt for you. Would you say it's true that stem cell therapy has actually been around for decades in one way or another with how we use it in medicine?
Wow. Yes and no. It's
Okay.
been around for decades when it comes to the slightly more complicated disease, graft versus host disease.
Yes,
Those,
that's what I'm thinking.
complication
Yeah.
after a bone marrow transplant. For that,
Yes.
that is how MSCs. It was not how they were discovered, but that how they became popular in the late 90s when Professor Katarina Leblanc at Karolinska Institute showed that for those who were terminally ill in what is called GVHD, graft versus host disease, a complication after bone marrow transplant, that 50% of them could be saved using MSC treatment. And that is when the entire field just blew up. When she started her research, there were around a couple of thousand published papers mentioning MSCs. Today, there are closer to 100,000, and I often say that you can throw a dart at the hospital organogram, and whatever clinic you hit, there's an ongoing trial. There are between 400 and 600 ongoing trials globally, and there's virtually no indication that they are not being tried on. We can come back to that, but it's based on the safety profile with no known severe side effects if you have the right cell source and you produce them in the right way. And then they're fantastic features, what they do. They're kind of
Yeah.
a solution looking for a problem.
Yeah. Yeah. And just for our listeners again to explain, MSC stands for
Mesenchymal stem cells. And to complicate it, which I'm not supposed to, it can also have the same acronym. It can stand for mesenchymal stromal cells because the cells are taken from what we call the stroma, which is also known as the connective tissue. Then there's a third explanation for this acronym because there is now a discussion in the field if they should be renamed medicinal signaling cells due to their mode of action. We'll come back to that later, I hope, because they do not engraft. They don't turn into your tissue. They help your body to self-heal. They enable your own body's healing function, and that is how they work, through signaling, so medicinal signaling cells. But
Yeah.
people in the field would just call them MSCs.
Okay. Okay. I love that though, that the acronym translates across all those different uses of the cells and really describes well what they're doing. So yeah, tell us like what you guys at Cellco. So I know you have your own practice, but you are working with Cellco, which is one of the companies well, the only company that we're using at Wild Health when we're recommending or thinking about stem cell therapy. Separate the signal from noise for us. What are we thinking about? What does science tell us? What does the research that you're helping conduct look at and say, this is a good indication? This may not be. This is, what we still don't know yet.
Okay, so I'll give you the answer that you do not want.
Okay.
And I'll start with really setting the scene on why MSCs are interesting and important. Uh, I travel the world 50% of my time. I've given lectures on this topic to regulators, university hospitals, physicians, longevity enthusiasts, and everyone in between. And yes, I am the CEO of the producing company, Cellcolabs. So I often quote a former dean at the Harvard Faculty of Medicine to really set the scene on MSCs. I was Professor Joseph Martin, who said that stem cell therapies have the potential to do for chronic diseases what antibiotics did for infectious diseases. And that is a really strong quote because 80 years ago, before the invention or discovery of antibiotics, many people died from simple infections. Children died from simple child infections. Uh, Elderly and frail died from infections. And even people like you and me, midlife, could die from a simple infection. We couldn't do, but we did it anyway, surgery. And then while we could do the surgery, people died from wound infections. The invention of antibiotics changed the world of healthcare. And now, 80 years later, instead of dying from infectious diseases, we die from chronic diseases, heart infarctions, stroke, Alzheimer, diabetes, and also suffer from life-impairing diseases such as arthritis, for example. So people much smarter than me, those who are the most brilliant in the field, they actually believe that the promise of stem cells will change. It will be a pivot. It will be an inflection point in the history of medicine where we can finally start attacking the chronic diseases. In some way, alleviate the disease burden, maybe even cure some of them. But for me, what makes me jump out of bed every morning and fight for MSCs to be readily available and affordable through Cellcolabs is the potential to prevent the onset of these major diseases that we suffer from in our time. And so, to your question, then, trying to find the signals and then separate them from the noise. As I said, you can throw a dart at a hospital organigram, whatever clinic you hit, there's an ongoing trial. The top indications, if you look at the ongoing research, the most research field is neurodegenerative diseases, where you have a lot of diseases that we cannot help with conventional healthcare today. Alzheimer, Parkinson, MS, ALS. The second biggest research field is on joints. And arthritis is the fourth biggest disease burden globally when it comes to people not being able to work or live normally due to pain. The third biggest research field where there is a lot of super good clinical trials, randomized and placebo-controlled, is in cardiovascular health, which is one also of the biggest killers of our day and time. And then, of course, you have a long list of other diseases, which I'd be happy to dive into. One of my favorite diseases when it comes to MSCs, except for cardiovascular disease, is actually inflammatory bowel disease. For example, Crohn's disease, where I think that MSC within the next 5 to 10 years, if it's not a cure, at least it will be used as the standard care, because there are now phase 2 and 3 trials showing amazing results where people can go off their other biologics. And once again, with the safety profile of MSCs, which we need to cover thoroughly, there are no known severe side effects, which kind of changes the life for these patients.
Yeah, that's fantastic. And I do want to get to the safety profiles because that's a big concern that that a lot of people have. But before we do that, I want to back up and kind of double click on two things we've talked about. I may use that term in the question I just asked, signal, and then kind of go back to something you said in your introduction about how these cells, and you said medicinal signaling cells is another way you can describe them. I think there's a large misunderstanding in the popular culture around how these things actually work. Right? They're not replacing cells that we had and growing into new cartilage, as an example, in the knee or something. So can you walk us through that, the kind of the process by which these things have their effect in the body?
It is as if we would have prepared this before, which we haven't. And I love the
Which
question. It couldn't be better because we're about to debunk one of the biggest myths within stem cell therapy. And what you and your listeners will learn now will make you smarter than many physicians, several clinical university hospital professors, and many others within the field of stem cells.
Get ready to raise your IQ, guys. Here we
I'll
go.
say this a couple of times. When using MSCs for treatment, they do not engraft. If you're treated, whether they're injected into your heart muscle or IV, if you have a heart infarction, if you get them somehow to your brain or in your knee, they don't engraft. They don't turn into heart muscle cells, brain cells, cartilage tissue in your joints or elsewhere. The cells work through signaling. If you get them IV, for example, independent of indication, they go into your blood system, they go around your circulation, and then they end up in the lungs. They stay in your body for 2 to 10 days, and they are then cleared by the immune system. During this time, what will happen? Because those are live, high-quality stem cells, if you get them from a decent producer. What they do, they will listen to the signals in your bloodstream, or if injected locally, they will listen to the signals in your extra cellular fluid. They will then respond to those signals because due to listening, they understand where is their injury, where is their inflammation, how is the immune system doing. And then they exert their three overarching effects for which there is a general consensus globally on what MSCs do. They do three overarching things. A, they decrease inflammation. Inflammation being the main driver behind aging, chronic diseases,
All
and
chronic
several
disease.
types of cancers.
Yeah.
On top of being anti-inflammatory, they are regenerative and can help heal damaged tissue. And number three, they can help boost or reset your immune system if it has gone rogue, as in autoimmune disease, when it starts attacking yourself. And due to these three actions, they are kind of, as I said earlier, a solution looking for a problem. They're interesting for almost any disease as such, and especially for the chronic diseases, which are mainly driven by inflammation and tissue damage and an immune system that has gone rogue. But I said this again, they do not engraft. They don't turn into your heart tissue, cartilage, or anything else. They work through signaling, and they help your own body, because these cells, they're taken from donors. And they're taken, and we'll get back to that as well, but they're taken from optimal donors, according to published science, and optimal donors between 18 and 30 years of age and in full health. And then they make your own body work, the recipient, the patient's body work, as if it was 25 or young again. And that is what the cells ensure. And this is great for many reasons, because as I don't engraft, they can't transfer any DNA or mitochondria or anything else from the donor. And of course, the donors are checked for everything. But what if there's an unknown doctor? What if the donor had an mRNA vaccination for COVID? Could it be dangerous for me? No, it is not, because the cells do not engraft. They come in as healthy stem cells, and they activate your own body's healing abilities. And that is how they perform or exert their effect.
Yeah. So is it fair to say, in a sense, they kind of reset the barometer in your body with inflammatory pathways? Is that correct, or is that not exactly what's happening?
That is one way to express it. Yes, they absolutely do. If we talk about how the body works in general, even if it's a healthy body that ages over time, whether you believe in one god or another, or just Darwinism and creativity, whoever created us humans as a species, initially we were not created to become 80 or 100 years old. We were created to become around 40, because at that age we have had our offspring, and we made sure that they survived, and then we were ready to be put on in the waste bin. So our bodies are set up to become roughly 40 years old, and we have our immune system that protects us from bacteria, viruses, and diseases. And that works kind of like an antivirus program in your computer. It runs low grade in the background all the time. And that is what creates the low grade systemic inflammation. And that is not the problem if you only live until 40 years. What happens even after 30, and then from 40 it becomes even worse, is that this low grade background inflammation, it increases. So what the cells do, by bringing down the inflammation, they slow down this inflammatory effect, and what it does to aging and the development of chronic diseases and so on. That is at least what is believed in the field by people who are knowledgeable, and that is what we see in science, and that is highly likely the reason why we see interesting effects on chronic diseases and many other diseases.
Yeah. Well, I think you've already referenced it, but let's spend a moment talking about these safety profiles. You mentioned that these cells do not become part of your body. They don't engraft, as you're saying, and turn into a heart cell or a liver cell. What other risks might there be? And tell us about what the research tells us there.
Research says that, well, let's start. There are four well-known tissue sources, connective tissue, tubular tissue sources, where you can take the tissue. You can take it from other places. The four mostly used ones are bone marrow, adipose tissue, which is fat.
Yes.
It is umbilical cord and placenta. There are some others as well, but those are the four big ones if you look at the ongoing science globally. Depending on the source, there are different risk profiles. the mostly used within clinical science is bone marrow, because with bone marrow there are to date no known severe side effects, no known severe adverse events. And so when it comes to safety, yes, there can be a local swelling after a local injection. You can have a slight elevation of your body temperature, and then other minor passing side effects, which you would expect independently if you get sodium chloride or paracetamol or anything else. But there are no known complications from using bone marrow-derived mesenchymal stem cells. And this is key. If they are produced according to GMP, good manufacturing practice, that is the highest and only quality level for use in humans. And this is super interesting. Whether you go for Cellcolabs cells with some of the partners that we work with, or you go with another provider elsewhere, I don't mind. What I do mind is if you go for cells that are not approved according to GMP, because that is when people get harmed, and that is negative for the patient, for the doctor, but also for the entire field. Because there are a lot of charlatans trying to push cells that do not live up to the highest quality. So wherever you go, your first question to that doctor or that provider should always be, are those cells produced according to GMP? And they shouldn't be GMP compliant. That means that somebody read the manual, said that I follow this. They should be GMP certified, meaning that FDA or another regulatory body has inspected and approved the provider.
Okay. So
If
that
this
was my next question. There is right now a handbook saying these constitute the GMP specifically for stem cells.
There is a global golden standard called GMP, and it may vary slightly between the US, Europe, and other local geographies, but they are virtually the same, and I would trust them if they are GMP approved.
Okay.
So if you have the GMP approved cells, going back to the 4 cell sources: bone marrow, adipose tissue, umbilical cord, and placenta. According to published science, they seem to be as efficacious independent of cell source. The efficacy will always depend on the donor and selecting the right donor, and that is a thing in itself. But looking at the safety profile, the reason why most why most clinical trials are using bone marrow cells is that there are no side effects. If you use umbilical cord, placenta, or adipose, there is a minor risk, but there is a risk of blood clotting, which may lead to a pulmonary embolism, which could be terrible. So when you hear about people, whether they've been to Mexico or elsewhere, and they don't return, most cases it's a blood clot that turned really bad. Could also be that the product is not sterile, which is once again why you should only go for GMP products, but because that is handled. So if you use a GMP produced product that is from bone marrow, there should be no blood clotting risk. And if it's GMP, there should be no problem with sterility. And of course, you need to have a good medical provider, because whenever you inject anything, if you don't have good needles and a good doctor, but that's a problem aside from the stem cell product. So I think GMP, if you can, go with bone marrow over the other sources. If you cannot, it's okay to use the other sources as well. The blood clotting risk can be offset using heparin or some blood thinner. Those cells also tend to have not an as nice, the patient journey is not as nice, because other cell sources are initially pro-inflammatory before they turn anti-inflammatory.
Okay.
The bone marrow cells are anti-inflammatory from the get-go.
From the get-go. Okay.
This is a different rabbit hole. We can dive into that. The layman explanation for the blood clotting and the inflammatory response is, what is if you think about especially umbilical cords and placentas, those cell sources, what is the biggest? They are leftovers from giving birth. So what is the biggest risk for mother and child when giving birth? It is bleeding to death at the
Postpartum
separation.
hemorrhage. Yeah.
So those tissues are highly procoagulatory, and even if you extract the MSCs from those tissues, they are still somewhat procoagulatory, and that is what may cause the embolism. But once again, with a good doctor, you can offset that risk. But and if you ask me, bone marrow and always GMP independent of cell source.
Okay. Great. Wow. Okay. You guys heard it. There's your questions to start with if you are looking into this. Can you differentiate? We've talked a little bit already about the local treatment versus like systemic treatment, something like IV. Can you dive into some of the indications that you're aware of, and then maybe if there aren't yet indications that have good science behind them, what do you think is on the horizon that may have a lot of promise?
Absolutely. So let's start with IV, intravenous, versus local injections. Why and for what? I am a big proponent of IV infusions, and I have a physician background from the emergency room at the Karolinska University Hospital. Many of the patients I saw was cardiac infarctions and other severe systemic diseases based on chronic diseases. And for them, an IV treatment would have always been the preferred treatment, because then the cells are kind of, even though they don't go to the site of injury, they listen to the signals in your blood system. They understand what is wrong, and then they signal back to that and start working with that. So an IV treatment will always look at what do you need in your body and start working with that. Um, Also, injecting something into the heart muscle or into the brain or getting past the blood-brain barrier, it is highly complicated, but it is also completely unnecessary. Because if you give them IV, the cells will signal to the place of injury and start working with that. And I have two examples which will actually bring us into the most interesting indications as well. There is an Australian company working in US with bone-derived mesenchymal stem cells produced according to GMP. They were looking at the disease called heart failure, which, if you're not in cardiology, it means that the heart is not pumping in an optimal way. So they, not knowing better, I would say, they're a great company, so I don't want to blame them in a way. They went intravasively into the left ventricle of the heart and injected a systemic standard dose into the heart muscle, hoping for the heart to move better. And it did slightly. The jury's kind of still out if it's clinically relevant or not. What they saw, though, and this was a big phase 3 trial, by the way, placebo control, 500 participants, 250 placebo, 250 received the cells. And the heart moved a little bit better in the cell group. But what was truly interesting, it's at the 30-month follow-up, so after 2.5 years, there was a risk reduction in the cell group for the risk of heart infarction by more than 50%. Actually 63% in the high-risk group, defined as those with the highest inflammatory levels. And for me as an ER physician, a 63% risk reduction for heart infarction, that's a mind-blowing number.
Mind-blowing. Yeah.
Yes. If I meet the patient in the ER with the first cardiac event, I give them 5 medications for the blood pressure, the statins, the beta blockers. And for each medication, which that person, often a 55-year-old male, needs to take once or twice per day for the rest of their life, for each medication, there's a risk reduction of 5 to 10% for having a heart infarction. So with 5 medications daily, there is a risk reduction between 25 and 50%. This
Yeah.
was a one-time treatment with the mesenchymal stem cells that showed a 50% risk reduction over 2.5 years. And now this becomes even crazier, because in the same group who received the cells, they also saw a decreased risk of stroke by more than 50%, actually 67% in the high-risk group, once again defined as the ones with the highest inflammatory levels. And once again, it's just crazy numbers. And to me, it says, well, at least two things. A, the cells were injected into the heart muscle, and they affected the risk of stroke. Once again, showing that the cells do not engraft. They don't only work locally, they work globally, and they work through signaling. Second, I think in this trial, they measured outcomes, secondary outcomes as heart infarction and stroke. If they would have looked at other things that were closely connected to the vascular system, whether it's the kidneys or the skin or something else, I would assume that they would have seen similar results. So that is one evidence data point to the fact that they do not work only locally, but they work through signaling.
And
Second,
if I can say something real quick, because what I find really interesting about that, they came in looking for heart failure, which we think is a functional, and you said there wasn't a ton of risk reduction or improvement there, but they ended up finding that, would you say 2 to 3 years later, these people were not having strokes,
years later,
heart attacks.
30-month mark.
God, Yeah, that is fascinating.
Mind blown.
Yeah.
Um,
Yeah.
to
Okay.
the same point, if you have a person with bilateral arthritis of the knee and you inject only one knee, you're going to see the most effect in that knee, but you're going to see an effect in the other knee as well. Because once again, the cells do not engraft. They don't turn into cartilage in that injured knee. They work through signaling, and they respond to the signals from the other knee as well.
Wow.
Yep.
All right, give us your second case. I'm sorry I interrupted you.
No, those were two cases: the
Okay.
heart failure and
And the
the
osteoarthritis.
arthritis of the
Okay.
knees. In terms of so I'm a big proponent of IV treatments.
Okay.
Then I know that we're working with a couple of the best MSCs doctors, orthobiologics in the world, working in US, who are working with our trials in the Bahamas.
Yeah.
And I know that it is not only that they do work locally with precision ultrasound or X-ray guided injections. You can inject them in the exactly right space and you see improved results. So of course there is a skill set and an upside of local injections depending on the indication. But for
Okay.
most other indications, I would say that IV is as good. There is some financial upside to doing local injections. For example, a systemic standard dose of IV treatment would be 100 million cells IV. If you do a local injection in a knee, that would be 50 million cells. And then there are other treatments, either within or outside clinical trials around the world, whether it is for hair growth or erectile dysfunction, whether you do local shots with 10 to 30 million cells. And of course, the cells are super expensive, but that is why we exist as a company. Based on the 25 years of science from Karolinska and one of the world leading scientists in MSCs, we have been able to we are allowed to use her lifetime of science to set up the production here in Stockholm, where we're FDA approved by the Swedish FDA, called the Swedish Medical Products Agency, to produce the cells for, according to GMP, for investigational use. So they're used in clinical trials around the world or within the regulatory frameworks as allowed.
Great. Well, yeah, I'm hoping that we can dig into some of that education you have as an economist too, so you can tell us a little bit about kind of what you're talking about right now. What are the, from the production and regulatory standpoint, what do you feel like are the biggest bottlenecks? Because to me, I still have a hard time seeing why, in the United States at least, we seem to have such a big problem with that. So maybe some of the theory around that, and then what do you think the bottlenecks are to holding up, this super expensive therapy right now, at least, that it seems could be so widely beneficial to so many in our population.
Oh, how much are you into
Do we need to do
aspiring?
another podcast
Yeah,
just
that's a
on
different
this?
podcast.
Yeah. Yeah.
15 years ago, MSCs were regulated as transplant tissue, because what you literally do is you take tissue or MSCs from a donor and then you give them to the patient. And let's just give the 30 seconds on how is that even possible. If you take blood from someone and give it to someone else, you need to match blood type. Everybody
Yeah.
knows that. If you take a kidney and give it to someone else, you need to match genetically. Everybody knows that as well. If you take MSCs, don't you need to match? No, you don't. Once again, a fantastic trait of these cells. They don't express the surface marker, so they are
Mm.
as good as immunocompetent. You can take them from anyone and give them to anyone else. And that is why you don't want your own cells, because most of the time they are not optimal, unless you're
Mhm.
between 18 and 30 and in full health, which most
Mhm.
people aren't. So that is why you take donor cells. When you screen a donor who has the perfect cells, you take only a small amount of their bone marrow, which grows back in 3 to 6 weeks, and from that amount, you can grow a huge number to treat between 200 and 400 people.
Con-
Um, so sorry, what was the question? What was I supposed to answer?
yeah, it was mainly about what else is
Yeah,
why is
the
therapy
bottlenecks.
not more widely available. Yeah.
Yeah. The biggest bottleneck globally are the charlatans claiming to do
Mm.
proper stem cell treatment according to GMP. Worst case, harming people, but as bad almost is people not getting the result they're paying for, which holds back the entire field, and why you have such a lot of
Mm.
questioning from conservative doctors. And I'm a doctor. I'm the CEO of this company, but before I was recruited to become the CEO, I knew what a stem cell was, but I had no idea what an MSC is. We don't
Mhm.
still have them in the textbooks in med school. You need to learn this because you're interested and read up on the published trials and the scientific papers, and it takes some time, which
Yeah.
is really interesting because the longevity community and the people who actually have different diseases, they are now looking at this and saying, this looks interesting. Doc, you need to read up on this to be able to give me advice. So that is maybe the biggest bottleneck. People not knowing and having heard all the bad things.
Yeah.
Remembering fetal stem cells from 20 years ago. Nobody's serious about stem cells or using fetal stem cells anymore. You have the moral and ethical problem with aborted fetuses, and on top of that, fetal cells may also be cancerogenic, which adult stem cells are not. So nobody today is using fetal stem cells for good reasons. You also may remember the coding of the sheep dolly, long time ago. Let's forget about that.
Let's
So
forget.
then you have the industry. It was regulated as transplant. Then it was overly used for commercial reasons, so it was re-regulated as what is called an ATMP, an advanced therapeutic medicinal product. So kind of just like a dry molecule product, which is a very difficult way you need to research it through phase 1, 2, 3 trials, which is super expensive for a drug molecule. It is super, super, super expensive if you do it for a stem cell product, which is so much more complicated and expensive to produce. So pure financials have held it back for a long, long time. And why is it so expensive? Well, it is super complicated to produce top quality, high efficacious stem cells. And the problem is that most producers, they do this at small scale. And now we get back to economics, because even if you manufacture a super simple plastic toy, if you build a factory, you employ all the people, you set up all the machinery, and then you produce one toy, it's going to be super expensive toy. So plastic toys that are produced in the millions, because that brings down the price. The problem is if you take a super, super complicated and a super, super expensive production process, as in stem cell production, and you produce them for only one patient at that university hospital who needs exactly that stem cell, the price is going to be through the roof. If you take the Cellcolabs approach, where we do large-scale, industrial-scale production of stem cells, not only for the patient in front of us, but as an off-the-shelf product, then we can produce, instead of doing 5 or 10 per year, like the Karolinska University Hospital would do, we produce some 2,000 per year. And the economics of scale brings down the price significantly. So what we've done since we were founded in 2021 is that we've done the tech transfer from Professor Katarina Leblanc at Karolinska Institute and from the Karolinska University Hospital, who produced it according to GMP for Professor Leblanc. We've done the tech transfer, we scaled it up more than 100 times, we've validated the process, we've applied to the Swedish FDA, we've been approved, and we're now producing at large scale. In parallel, we're working on the next production technology, which is to use bioreactors. So that's a step change in terms of output. So we've increased by 100-fold already, and we think that we can increase by another 20 or 40 times within the next few years. So in monetary terms, we've already cut the price by 50% or even 66% compared to what Karolinska produced the cells for. And we think that we can slash prices another 80-90% over the next decade with the upcoming technologies. So that is truly making the cells available and affordable, which is much needed to accelerate the research and make them available for patients and people in need.
Yeah, 100%. People in need, you've already mentioned neurodegenerative disorders, and talk about a gray area for us, right? In medicine, we just don't have good ways to treat those things. So I'd love to hear anything that you are doing with Cellco, or that you're aware of in the literature around that, and also around, you mentioned, I think, irritable bowel syndrome, or was it inflammatory bowel disease? I'd love to hear about any research in the autoimmune world, because that is something that we see a ton at Wild Health, and just hard things to treat, right?
Yeah. I'll
Yeah.
Oh, I don't even know where to start. One of my
Yeah.
favorite indications right now is Crohn's disease, so inflammatory bowel disease. It is an autoimmune disease. It is an inflammatory-driven disease where you have terrible symptoms from your intestines, pains and diarrhea and bleeding. And There are some you take huge amounts of cortisones trying to hold it down, and then there are biologics as well. But there's no cure for it. And what is now shown with MSCs derived from bone marrow is that they seem to be a way to control the disease, to put them in remission, and we don't know for how long, but the cases I know of, they've been able to go off many of their medications after 3 or 4 consecutive treatments. And this goes back to what I said earlier. How do they work? Well, they work together with your immune system, sets it right if it has gone rogue, as in autoimmune disease, when it starts attacking your own body. It seems to clear a lot of those antibodies attacking yourself. And they can also boost the immune system if it's weak or frail. There's another autoimmune disease, diabetes type 1, the one which most often kids get. And suddenly the attack or the immune system starts attacking the insulin-producing beta cells in the pancreas. It's also, for some reason, the immune system creates antibodies. And what is shown by Professor Blanc using her cells that we are now producing, there's another Swedish company working on this as well, using a different tissue source. It seems like if the patient is treated within the first 3 months after the diagnosis of type 1 diabetes, they seem to get into honeymoon phase where they need less insulin and they have a better disease progression afterwards. The problem is that due to the cost of the cells, in most of these trials, the patients only get treated once. What if they would be treated every 3 months after diabetes type 1? Could they uphold their insulin production for a year, for 2 years?
Yeah.
What an amazing effect would that be for that child? So
Yeah.
that is another autoimmune disease where I think this is super interesting. Rheumatoid arthritis is another
Autoimmune disease.
yeah.
Yeah. It sounds like maybe it looks very promising in that autoimmune field, but a question might still be the frequency of therapy. Is that correct? We don't know if we need to do that. The idea that you could actually heal Crohn's and get people off of these medications that often put them at risk for other things,
Yep.
other diseases or immune suppressant medications. So that's mind blowing. That could be
Yeah,
earth
the
shattering.
idea is mind blowing, and I'm not saying that it's a cure, but it seems to be a way at least to control the disease.
Yeah.
And if you can control the disease properly, you decrease the risk of developing cancer, which is a risk if you have inflammatory bowel disease for long term, which will, I mean, it could potentially change their lives dramatically.
Yeah, yeah. And
Yeah.
along the neurodegenerative diseases, is there some literature coming out around Alzheimer's, Parkinson's,
Yes,
ALS?
there's
Those type.
amazing literature or published science that came out from is it the University of Miami, where they treated, and in that latest trial they treated the patients, I think 2 or 3 times, but it was small doses and within a short time span. I would like to see the trial that I haven't seen yet, where you get a systemic treatment with 100 million cells every 3 months for 2 or 3 years. That is yet to be conducted. What is known from the stem cell um, tourist industry is that it seems that for early Alzheimer patients, there may be effects holding back the disease progression. And if you Google it, you'll find it. Once again, those are anecdotal cases, but you hear them again and again and again, and I've seen them as well, and I've spoken to patients who've tried it, and I've seen effects. But this is anecdotal. I want to be very clear with the listeners on that. The published trial that I mentioned coming out from Miami, that is not anecdotal. That is published science showing benefits in most of the different verticals where you have a problem if you have Alzheimer. And once again, the safety profile is there, which is super interesting because, as you may know and your listeners may know, in the last 1-2 years, there has been, I think, 3 or 4 new medications for Alzheimer. And they hardly move the needle on disease progression, 5-10%. Though they come with potentially terrible side effects with brain bleeding and brain swelling.
Yeah,
So, in terms of safety, if I would have Alzheimer, I would obviously start with the MSCs if it's within my financial reach. But one must know that it's not a one-off treatment. You would likely need to be treated several times per year. In time, there will be science to show for who it's good and who does not benefit from this. But I think that is another disease area where we'll see a lot of progress over the next 5 to 10 years.
Okay. Okay. Yeah. Yeah. Boy, that would be another world changer. Are there any other conditions or interesting research you know of going on for, things we haven't applied stem cells to yet but think may be beneficial?
Um, yeah, yes and no. If I may future gaze and
Yeah.
really go out of outside the scientific box, and maybe go back to the comparison with antibiotics. We did surgery in healthcare before antibiotics, but people died from wound infections. Um, Now that is not such a big problem anymore. What we do know about the MSCs is that they improve healing of tissue, and that is not only after sun exposure or after a car crash. I mean, surgery is actually a form of a controlled trauma where you cut something away to make
Yeah.
it better. So just like if you have a hip fracture, for example, you get a shot of IV to reduce the risk of wound infection or prosthetic infection if it's a hip prosthetic. I think within the next 5-10 years, you will get a shot of MSCs as well to improve the healing and decrease rehabilitation. Uh,
Wow. Yeah. That would be huge. Cut down on that rehab time. I wonder about for chronic wound therapy, if there's any.
wow. Yes, absolutely. Chronic wound therapy. I mean, this is a super big thing in aesthetic surgery as well, where you want to decrease the
Yeah.
scarring.
Yeah.
On that note, completely different. There's been a trial in Sweden using MSCs for chronic hoarseness, which is scarring of the vocal folds.
Yeah.
And as a ear, throat doctor, you can shave those that scarring away, but it grows back with new scarring. And what the trial showed that if you, as an ENT doctor goes in, you take the scarring away and inject some MSCs, the vocal folds heals with lesser scarring, and the patient gets some of their voice back. And that's the same effect as you would see whether it's in aesthetic surgery, hip surgery, or vocal fold surgery. So it's super interesting from that perspective.
Yeah, for sure, for sure. Well, man, we've covered a lot of the indications. I feel like we've outlined very clearly the safety profile, which hopefully everybody feels better about now after listening to this. And obviously, the overarching theme here has been to remind people these are not new lung cells or new liver cells you're getting here. This is a systemic effect. A lot of our listeners are going to be really interested in the potential for anti-aging effects outside of the obvious, because we talk about that a lot at Wild Health. Like, well, our medical system tries to put things in silos, right? And say, I'm a cardiologist, your heart's fine. I'm a gastroenterologist. Thinking about the aging process in general is kind of the number one risk factor for all chronic diseases, if you could kind of classify it as that. What do we know about how this can actually slow the aging process? Do we have any data around that yet?
We have no good data on
Okay.
that yet. I often get the question, will with MSCs available, can we live forever? No. To live forever, you need CRISPR and gene editing, but I'm not sure you want to go that way.
Yeah,
Boost your intelligence first, and then think twice before wanting to live forever.
exactly.
The promise of MSCs is that if we have maybe 110 or 120 years that the human body is set up to be able to live for different reasons, then what modern healthcare has done within the past 40 years, that it has expanded lifetime by 15, 25 years, but it has expanded the lifetime between 60, 75 and 80, 95, the years where we're not in full health anymore. And the hope and the promise of MSCs is that we can prolong our healthy lifespan. So the time between 35 and 65 maybe.
Yeah.
So I often say that I want to go for 105 or 110 years. And I understand that at the end of that process, at some point, I will get older and get all the chronic diseases, and that's fine. And at some point, it's too bad and I don't want to be around anymore. This is not the fountain of youth, but it has a huge potential for a healthy lifespan.
Okay.
And by the
So
way, super costly treatment. Please remember the 5 things you can do for free. Number 1, sleep. Number 2, have friends in a social setting, even if it's only nodding to the cashier at Tesco or Walmart or wherever you go. 3 and 4, I never remember the order. Eat right, healthy, and do your exercise. And number 5 is avoid doing drugs, alcohol, nicotine included. Um, I'm a physician. I'm a stem cell, a pharma company CEO. I'm a father of 2. I should get all of this right. I don't. As you noted, I'm a night owl. I sleep too little. I work too much. From culture, I do enjoy the occasional glass of wine. It is hard to expect everybody to be perfect,
yeah.
and so we need some cheats.
Yeah.
And I think stem cells could be one of them to prolong our healthy lifespan.
Oh, I tell you what, we could not have closed that any better because that's always our message to our patients. Do the things through your lifestyle modification company and make sure you're hitting those 5 things that Dr. Bernow just mentioned. I think that is the cornerstone of what we need to live long, healthy lives for sure. But I think you're exactly right. This looks like some real promise to improving the quality of those those years lived, right? And I guess in a sense, I know you said they're not slowing aging and that we're seeing any of these biometrics that we can track now, like epigenetics, which we do a lot of. But I guess secondarily they are because if we're seeing that they do reduce your risk of having an MI or having a stroke, then yeah, you could argue that's probably improving both health span and lifespan.
Thank you. They likely will. If we if we get diseases later, then we will likely die later as well. But
Exactly. Exactly. Yeah. Yeah. Well, man, it has been such a pleasure today. Anything in closing that comes up that you think about, you've talked to other people about maybe that I haven't asked yet? Anything you can think of to relay onto our audience?
I think my main message is GMP. Yes, Google Cellcolabs, you'll find where you can have our cells through our partners or through our own clinical trials. We'd be happy to help you. By the way, you can contact us, and
Yeah.
there's a free consultation where you get to speak to highly educated nurses who will answer everything according to published science. They will tell you whatever you need, and then you can go with us, you can go with someone else. But the most important is do get informed and make sure wherever you go, make sure that you get GMP cells. If you
Yeah.
don't, you put yourself at risk, you put your doctor who recommended you at risk, and you destroy for the entire field. Please make sure to always use GMP cells because we're standing at an inflection point in the history of medicine, and everybody should work together to make this available.
Man, couldn't have said that better. And I personally can attest to what Dr. Bernow just said. I have reached out to Cellcolabs with questions for myself about patients to be able to educate them, and they have been very helpful. So, sent some folks to you guys as well, and have had great experiences. So, yeah, where can you guys find Dr. Bernow? Well, the website is simply cellcolabs.com, correct? Okay.
Absolutely. That's our production company in Sweden. And then cellcollabsclinical.com, you can find our clinical trials and read up and understand more about them.
Okay, great, great. Well, thank you so much for joining us today. It's been an education for me and hopefully for our listeners as well. I look forward to communicating with you and Suckle Labs more as this field continues to grow, and having a trusted partner in this space just feels really good for us. As you mentioned, that we know is following the GMP regulations. So yeah,
Thank you so much, Jeff. Thank you for having me on. And if you have follow-up questions from you or your audience, I'd be happy to speak to you at any time. Thank you so much.
sounds great. Yeah, guys, we'll post some information in the show notes about how to get in touch with Cellcode Labs in case you missed those websites and social media handles. I think Cellcode Labs on LinkedIn is something I've also started following. So yeah, we'll put that in the show notes. But thanks again, guys. Hope you've enjoyed this episode of the Wild Health Podcast. I know I did, and we'll see you soon.
Stay healthy.
Thanks so much for listening to the Wild Health Podcast. If you want more daily health education, be sure to follow us on Instagram, which is filled with health optimization how-tos, grocery shopping lists, guided breathwork posts, myth debunking, and so much more. You can find us at Wild Health MD on Instagram.